Gestational trophoblastic disease is an reproductive health issue, pregnancy related disorder. Look at this picture, shows that uterus, an abnormal trophoblastic, ultrasound findings. Look at this chest X-ray to identify metastasis and CT scan findings. Look at this MRI, clearly visualized, a detail going on. Introduction. Gestational trophoblastic disease is a rare group of pregnancy related disorder that arise from abnormal growth of trophoblastic cells, which are the cells that normally develop into the placenta. GTD can be benign or malignant and affects women of reproductive age. Early detection and appropriate management are crucial for improving prognosis and reducing complications. Definition. GTD refers to a spectrum of diseases that results from abnormal trophoblastic proliferation following fertilization. These diseases can range from benign forms such as herediform mole to malignant condition like choriocarcinoma. Etymology. The term gestational trophoblastic disease originates from the Latin word gestare, meaning to carry, referring to pregnancy, and trophoblastic derived from Greek words trophy, nutrition, and blastos, jam or sprout, referring to the placental cells involved in fetal nourishment. The word disease signifies the abnormal proliferation of these trophoblastic cells, leading to conditions like herediform moles and choriocarcinoma. Types. 1. Herediform mole. mole or pregnancy. Classified into complete mole, no fetal tissue, only trophoblastic proliferation. Partial mole, some fetal tissues present but abnormal and non-viable. 2. Invasive mole, locally invasive mole that can penetrate the uterine wall. 3. Choriocarcinoma, highly malignant trophoblastic tumor that can spread rapidly to other organs. 4. Placental site trophoblastic tumor, a rare type of GTD that invades the uterus and blood vessels. 5. Epithelioid trophoblastic tumor ETT, a rare and slow growing GTD variant. Causes: 1. Abnormal fertilization leading to excessive trophoblastic proliferation. 2. Genetic abnormalities, eggs or sperm. 3. Complete mole occurs when an empty egg is fertilized by a sperm, leading to paternal DNA duplication. 4. Partial mole results from fertilization of an egg by two sperm, resulting in a triploid. Karyotype. Risk factors: 1. Maternal age extremes, less than 20 or more than 40 years. 2. Previous history of GTD. 3. Asian, African or Latin American ethnicity. 4. Dietary deficiencies, low carotene and vitamin A intake. 5. History of miscarriage. 6. Infertility treatments or hormonal imbalances. Complications: 1. Persistent gestational trophoblastic neuroplasia GTN. 2. Uterine perforation. 3. Hemorrhage and infection. 4. Pulmonary embolism. 5. Infertility in severe cases. 6. Metastasis, lungs, liver, brain, etc. Pathophysiology. Pathophysiology of gestational trophoblastic disease, step by step process. First step: 1. Abnormal fertilization. 2. uncontrolled proliferation of trophoblast. 3. Formation of cystic structures. Molar pregnancy. 4. Excessive HCG production. Syncyto trophoblasts produce high levels of human chorionic gonadotrophin. 5. Inversion of uterine tissue. 6. Metastasis in malignant GTD. Choriocarcinoma spreads hematogeneously through blood, causing distant metastasis. Symptoms depends on affected organs. Example, hematitis in lung, metastasis, neurological signs in brain involvement. 7. Persistent trophoblastic disease (PTD) and malignancy. If molar tissue persists post evacuation, it may progress into invasive GTD. Persistent disease requires chemotherapy or surgical intervention. This stepwise breakdown explains how GTD develops, progresses, and potentially leads to malignancy. Signs and symptoms. 1. Abnormal vaginal bleeding. 2. Excessively high HCG levels. 3. Hyperemesis gravidarum. Severe nausea and vomiting. 4. Enlarged uterus inconsistent with gestational age. 5. Preeclampsia before 20 weeks of gestation. 6. Absence of fetal heart tones. 7. Hyperthyroidism symptoms due to high HCG levels. Diagnosis. 1. Ultrasound. Snowstorm appearance in complete mole. Presence of abnormal placental tissue with no fetus. 2. Serum HCG levels markedly elevated in GTD cases. 3. Histopathological examination confirms presence of trophoblastic proliferation. 4. Chest X-ray and CT scan detect metastasis in malignant cases. Nursing diagnosis. 1. risk for infection related to uterine evacuation. 2. Acute pain related to uterine distension. 3. Anxiety related to cancer risk and fertility concerns. 4. Deficient knowledge related to disease process and treatment. 5. Risk for hemorrhage related to trophoblastic inversion. Medical management. 1. Evacuation of the uterus. Suction, curettage is the preferred method. Hysterectomy in case of malignancy or completed childbearing. 2. Chemotherapy. Acetinomycin D for malignant cases. 3. Follow-up care. Serial HCG monitoring for at least 6 to 12 months. Contraception to prevent pregnancy during follow-up. 4. Radiation therapy using in metastatic GTD. Nursing management. 1. Monitor vital signs and vaginal bleeding. 2. Administer prescribed medications and pain relief. 3. Educate the patient about the importance of follow-up HCG monitoring. 4. Provide emotional support and reassurance. 5. Assess for signs of complications such as hemorrhage and metastasis. Treatment options. 1. Surgical evacuation, dilatation and curettage DNC, or hysterectomy. 2. Chemotherapy, single agent or multiple agent therapy for high risk cases. 3. Radiation therapy for metastatic GTD. 4. Hormonal therapy, regulated contraception to prevent pregnancy. 5. Targeted therapy, emerging treatments focusing on specific cancer pathways. Psychosocial medicine, counseling and emotional support help patients cope with loss of pregnancy and fear of malignancy. 2. Support groups, connect with others experiencing similar conditions. 3. Psychological therapy manage anxiety and depression related to diagnosis. 4. Educational programs inform patients about follow-up care and fertility options. 5. Family involvement engage family members to provide emotional and practical support. Prevention 1. Adequate prenatal care to detect abnormalities early. 2. Genetic counseling for women with a history of GTD. 3. Dietary modifications, adequate vitamin A and folate intake. 4. Contraceptive use to prevent early pregnancy before HCG normalization. 5. Regular follow-up for women with previous GTD to monitor for recurrence. In conclusion, gestational trophoblastic disease is a rare but serious pregnancy related condition that requires early diagnosis and appropriate management. While most cases are treatable, continuous follow-up is essential to prevent complications and recurrence. Comprehensive medical care, nursing interventions, and psychosocial support play a crucial role in ensuring positive outcomes for affected women. Thank you. Have a nice day.